Okay, here we are looking at second half of the cranial nerves and brainstem topic. We stopped on the glossopharyngeal nerve, cranial nerve number 9. The good news here that by its composition is very, very similar to vagus. While the peripheral territory will differ, the components are very, very similar. So we're going to be seeing a very small branchial motor component, goes to stylopharyngeus muscle, also part of nucleus ambiguus. And you would learn this in theory, and you just need to know nucleus ambiguus. It's mainly vagus, a little bit of glossopharyngeal. Now, keeping in mind, this is, of course, a lateral view, and we have that mid-sagittally sectioned brainstem made transparent for us so that we can see these cell groups. So that's one of our motor cell groups. And, of course, we have a visceromotor component in the inferior salivatory nucleus. It's kind of an equivalent area, but a little higher up in the brainstem, equivalent to where dorsal motor nucleus of the vagus would be. But I will never, ever ask you to point to inferior salivatory nucleus in a brain section. I would have a hard time, too. But in theory, do we need to know that it belongs to glossopharyngeal? Absolutely. Do we need to know that it signals to a parotid gland via the otic ganglion? Yes, we need to know that. And then also there is a taste recipient zone, again here, of nucleus of solitary tract that gets taste from posterior tongue via glossopharyngeal nerve. And a small somatic sensory innervation area. Of course, it goes here, joins the spinal tract and spinal nucleus of the trigeminal, kind of a variable area around the external auditory meatus, some around the tonsils too, and the back of the throat. Some of it is also innervated by glossopharyngeal. So you may want to keep that in mind. And other than that, you're kind of seeing this overall situation in a cross-section. So pretty much what I just showed you on the previous slide. So why should we care? So because of their closeness in topography, nuclei of vagus and glossopharyngeal nerve are often lesioned together. So for example, by a vascular insult, and that's going to be inside the brainstem. There will be other signs that we'll be learning. It's because of pathways and other signs that we need to know. So that's one important reason. And part of this may be the finding that the gag reflex may be deficient. So the afferent arm of that gag reflex, when you put the tongue blade or something like that into the throat, okay, the afferent is carried by glossopharyngeal, but the motor, the output, is running in the vagus. So you're testing potentially the integrity of those both. And just like there is trigeminal neuralgia, and it's much better known, trigeminal neuralgia, but occasionally you might see glossopharyngeal neuralgia for poorly understood reasons. When there's a lesion of glossopharyngeal nerve, and for example, very intense pain, but unexpectedly coming from these areas, and these people are so afraid, they're even afraid to eat and swallow because of it. So it's kind of a rare situation. So now we're transitioning to cranial nerves attached to the medulla pons junction. So number 6, abducens, being medialmost, and then 7 and 8 are at that pontocerebellar angle, very close to that little piece of of choroid plexus coming out of the foramina of Luschka. Of course, it's bilateral, right? All right, very, very good. So abducens nerve, cranial nerve number 6. Big story. So this is one of those cases where we have a longitudinal view from midbrain through medulla, and actually we get to see 3 cranial nerves. We are only focusing on our abducens nucleus, but the large concept is really the coordination of eye movements that will require all 3 of them. Okay, so that's our big picture and the big target. So right now we're just focusing on abducens nucleus, the motor neurons that live here. So this is a caudal pons, abducens motor nucleus. So they project out using this red arrow here. We go there. It will innervate lateral rectus for lateral gaze. And of course, you test that voluntarily also in a patient. Look to your right, look to your left, and you watch the patient. So while at the same time, so these are the motor neurons, but there are interneurons that are also activated, and they do a number of things. So they actually project to the contralateral medial longitudinal fasciculus, and innervating the oculomotor nucleus, and innervating the medial rectus, so that on the contralateral eye, the medial rectus will contract to do this, so for conjugate eye movements. Well, sometimes there is a lesion in medial longitudinal fasciculus, and we call that internuclear ophthalmoplegia. On attempted lateral gaze, the opposite eye does not cross the midline. So even in the absence of actual abducens palsy, and that can occur too, and let's say a lateral gaze palsy, okay? But even in the absence of that, you may get, and in many cases, for example, in multiple sclerosis, because disease of central white matter, and this is a white matter tract, it may occur. There might be an internuclear ophthalmoplegia, lesions of this pathway. But the basic, most important message of this slide is localizing abducens motor nucleus, understanding that the facial nerve loops around it, and this gives you the facial colliculus, that little mound on the floor of the fourth ventricle in this territory. So this line, as well as this line, signify the facial nerve, and then a longer line at the right level would come out as the abducens. So very much like what we observed with the hypoglossal, this is also a somatic motor nerve very close to the midline, and then the nerve is coming out medial most, right? Awesome. So going into the facial nerve, which is a very complex nerve, let's think about the peripheral targets of innervation. We'll find quite a little bit of everything. There's branchial motor, and that's certainly the largest component. The largest component is for the innervation of facial expression. It also does stapedius, posterior belly of digastric. But this is a huge function originating from the motor nucleus of the facial nerve. That's motor nucleus in caudal pons for this. You see that? And the visceral motor, aka parasympathetic, lacrimal, submandibular, sublingual glands. Now we get to use our superior salivatory nucleus. Remember, inferior salivatory nucleus for glossopharyngeal, for the parotid gland through the otic ganglion, that sort of thing. If there is an inferior, there's always a superior. Here it is. superior salivatory in the case of the facial. Okay, again, you don't have to be able to point it, just know it and associate it with this nerve. Now the sensory components, taste, anterior 2/3 of the tongue. That's really the largest. It'll go to the taste recipient zone, the lateral zone of nucleus of solitary tract. No surprises there. And again, there is this variable territory near the external acoustic meatus where a little bit is coming from vagus nerve, a little bit from the glossopharyngeal nerve, a little bit from facial nerve in unpredictable combinations. So sometimes in case of Bell's palsy, it may involve some of those fibers, not just the motor fibers, and patients will report some strange altered sensations there. Now, centrally, again, as I mentioned this before, and this is your concept again, there is not a separate somatic sensory system for each of these nerves. Whatever nerves have somatic sensory territory, centrally they will join the system of trigeminal. And of course that will report to the thalamus, and the thalamus will report to cerebral cortex from there. Okay, so this is kind of a summary of facial nerve in a cross section. So we're recognizing facial colliculus, but what it is, it's not the nucleus. So that's deeper, facial nucleus. So now we're looking at caudal pons, of course, but it's the nerve root looping around. So you may find a level where there is this nerve root looping around the abducens nucleus and makes an elevation. And this actually comes out here. So that would correspond to your pontocerebellar angle. Look at that. So in white, so Nolte has drawn this based on the actual image, right? Okay, so you get that. And as I said before, occasionally these two may be lesioned together. So the abducens nucleus and the fibers of that facial nerve itself. Okay, that's your facial colliculus, and the bend is the internal genu of the facial nerve. Summary of facial nerve, same story, but from this mid-sagittal view. Motor nucleus, superior salivatory nucleus, we need to know what it is. And then there is that very small somatic sensory area, and then the taste, that really big anterior 2/3 of the tongue, right? And they are sorted out centrally. Okay, so here it is again, supranuclear control, all right? That facial motor nucleus has a unique supranuclear control. It is, in fact, a facial nuclear complex with subnuclei going to groups of motor neurons and containing groups of motor neurons being responsible for various portions of the face. So the supranuclear control, the part of the facial nucleus that innervates the lower half of the face, so mid-face and lower, coming from contralateral cerebral cortex. However, the upper face, lower motor neurons, for the wrinkling of forehead type of function, receive bilateral drive. So this has great clinical relevance, so much so that neurologists will call one lesion, quote, peripheral facial nerve lesion, which means even though it may be inside the brainstem, but it's a lower motor neuron lesion, nuclear or infranuclear or completely peripheral, that's your typical Bell's palsy. It's an entire drooping of face and inability of wrinkling forehead and all of those tests that you do. So then the entire ipsilateral face is out motor-wise. Now, in the case of a hemispheric lesion or just below the hemisphere, when you get lesion on one side, well, the other side, which is intact, can still contribute to the motor neurons that are responsible for the wrinkling of forehead. So wrinkling of forehead is spared, whereas mid-face, lower face is paralyzed. That's a bad sign, in essence, suggesting a supranuclear lesion, as opposed to something that can be very benign, in the case of Bell's palsy, that peripheral lesion, right? And maybe idiopathic, or because of a virus or something. Okay, awesome. So we're moving once again even more laterally. So these two nerves, 7 and 8, are very close, but 8 is even more laterally tucked into that corner, the cerebellopontine angle. Well, lucky for us, all sensory, think very logically vestibular and cochlear. Vestibular is the larger division. It has quite a few. My inferior cerebellar peduncle, ICP, so this is a blown up version of this, very rostral medulla, right? Okay, is my anchoring point, and I just look adjacent to it. That's where I expect all of my vestibular nuclei. And the cochlear nuclei, I would go a little higher up, but they start at this level and even higher a little bit, pons medulla junction. So wherever you see these, that's your cochlear and vestibular nuclei. And then we'll be looking at central pathways later. All right, just understand we have these nuclei, cochlear and vestibular nuclei. It's not a very small territory stretched out, but lateral, and think high medulla, lower half of the pons. It looks like this in a cross section once again. Nuclei of cranial nerve 8 next to that inferior cerebral peduncle. Of course, myelin stained, right? So I'm expecting my inferior cerebral peduncle, all of those vestibular nuclei. I will not ask you to differentiate medial from lateral and that sort of business, although there is a difference. I mean, we talked about vestibulospinal pathways and that sort of thing from those nuclei, and they get input from cerebellum, all of that. So of course they are parts of systems, right? But if you just look at them in isolation, that's how they are, and then your cochlear is really the beginning of that central auditory pathway. Now the really big gorilla that we have to tackle is the cranial nerve of the pons, or the fifth cranial nerve, trigeminal. So the trigeminal, well, large sensory root and small motor root. So, very, very important to consider the trigeminal sensory territories according to the three divisions: ophthalmic, mandibular down here, and maxillary division in between, right? A small motor root, not that it's unimportant, but it's smaller in size, and of course it's gonna go to these muscles of mastication. So masseter and its function is typically the most important one clinically that you look at, masseter muscle that you look at from the motor. Now, bottom line is there is a complex organization for the sensory and motor components. So the sensory that you see in red here in the side view, and the motor that you see in blue. And the motor, just recognize the principal motor nucleus, okay, mid-pons. The nerve is attached at mid-pontine levels, right? It comes in. And then the sensory will do a number of things. And this is probably the most important slide to get you started for trigeminal, goes to that understanding of the trigeminal. What the heck is that? So when you're asking that question, go to the slide. So as I mentioned before, the sensory modalities are segregated anatomically and functionally in these cell groups. So the primary afferent neurons, with the exception of these, are in trigeminal ganglion. So now what I'm looking for is really the central termination of those primary afferents, with the exception of these, okay? So then what ends up happening that all of these, the pain and thermal and non-discriminative touch afferents from trigeminal territories terminate in the spinal trigeminal nucleus. We are really that dogmatic about it. So we just say that's the long column. Actually, that has a somatotopic organization. It actually stretches down to the caudalmost parts of the medulla. This is the one that's equivalent to the substantia gelatinosa of the spinal cord, because it has the same function for the termination of nociceptive and thermal afferents for the most part. But anatomists gave all of these names of caudalis for the caudalmost component looping down into the medulla. And then second order neurons will all send their axons to thalamus, of course, from here. But then, again, somatotopically organized a little higher up from other regions of the head and face. Some of the neurons would be here, and so on, and so forth, all the way up to the upper portions of the pons. There's this long column, the equivalent of substantia gelatinosa of spinal dorsal horn, so much so that some authors will call this, quote, the medullary dorsal horn. Most of it goes through the entire medulla oblongata. But we refer to it as the spinal nucleus of the trigeminal. And discriminative touch from face and oral cavity, those afferents will terminate in the principal sensory nucleus. That's at the level where the nerve root is. So mid-pons, and a little higher up. Now the important exception. So from proprioceptors, from those muscles of mastication, this is the only place, really, in the nervous system where primary afferent neurons, pseudo-unipolar neurons, are not in the peripheral nervous system, but they're somehow embedded in the central nervous system, and we call that mesencephalic nucleus of trigeminal. And it starts in the pons and it goes into, you guessed it, midbrain, right, a little bit. They're very, very unique. So this slide is key, but understand the three distinct modalities, and there are neurons associated with them. And this is the grand summary. So the sensory components overview. How do you get started? Well, let's suppose we look at nociception, that is red in this figure. So look at the termination of the afferents. So they loop down, they find their second order neurons, and just like the anterolateral system for the rest of the body, that spinothalamic tract, there's a trigeminothalamic. Eventually that's gonna go up to thalamus. Okay, but see what they do, right? So all of these levels, when you put them together, constitute this long column that we call spinal nucleus of trigeminal. So then your touch sensations and fine touch and that sort of thing, they'll go to the principal nucleus. And of course, there's second order projection from there that will go to thalamus, right? So eventually they'll be joined. So these are two separate modalities, but they're being processed in a parallel manner. And of course, your proprioceptors are unique, and from the mesencephalic nucleus, they can close a local reflex loops onto the nearby motor nucleus, the motor, and that will be here. Principal sensory and the principal motor nuclei. So what ends up happening that the proprioceptors that signal through the mesencephalic nucleus, they will make monosynaptic connections to your principal motor nucleus, and hence the jaw jerk reflex becomes the only stretch reflex that you can test that is outside the spinal nerves territory, the only cranial nerve that has that type of reflex. And sure enough, in the case of an upper motor neuron lesion, you get hyperreflexia. More about this later. So it's clinically important to test it. Okay, so that's your reflex, the jaw jerk reflex or masseter reflex, where the afferent and the efferent arms both are carried by trigeminal. And it's the equivalent of a myotatic or stretch reflex. Now the corneal or blink reflex, the afferent arm is in the ophthalmic division of trigeminal, but the efferent arm to close the eye is in facial nerve. Very good. So this is so-called atlas of the trigeminal system that I imported from one of Nolte's resources. So just to give you the idea that recognize the level. Caudal medulla, mid-level medulla. Yes, open medulla, that's their business. But spinal trigeminal nucleus, that long column, of course, is going to be here, next to the spinothalamic tract, actually. So having those tightly packed neurons, and then it kind of is continuing and it will go up. That's your pain and thermal afferent termination zone, right? And then when you're in mid-level pons, now that will reveal the location of principal sensory and motor nuclei. So you're cutting at this level, you end up with a section like this, and all of this gray that I'm seeing here, well, your sensory is always more lateral, motor, large neurons, more medial, mid-pons. The principal sensory and motor nuclei. And motor nuclei are a little bit more ventral to still above your medial lemniscus. So you see, we're not forgetting what we learned about the pons, that only this much is really tegmentum. Only this much is tegmentum. The rest of it is that out of proportion pontine base. And of course, there is relay in the thalamus. And the VPM does that for the trigeminal system, ventral, posterior, medial. Nucleus of thalamus that will project to the face and head area of your somatosensory homunculus, you could call it. Awesome. So the final two nerves are the cranial nerves of the midbrain, trochlear and oculomotor. And you might recall that oculomotor lives in this oculomotor nuclear complex. Well, for two very important reasons, because there are subnuclei for the somatic motor component, and that's the larger one, for the medial rectus, and superior rectus, and all of them, that are innervated by oculomotor, there will be motor neuron pools in that sense. And also it's a complex because the adjacent Edinger-Westphal is going to give you the parasympathetic or autonomic motor neurons. Now that describes your oculomotor, but we're going to be looking at the organization of it. So once again, lateral view, we're poking up here. So we have that oculomotor nucleus. Edinger-Westphal is nearby. That's your parasympathetic motor. So your somatic motor is the plain old oculomotor. Just ventral and lateral to central canal. We'll point that out from cross-section 2. The visceral motor is Edinger-Westphal. Everybody needs to know that name and what it does, okay? So that somatic motor innervates all of these muscles. Edinger-Westphal via the ciliary ganglion, postganglionics, will go to ciliary muscle, sphincter pupillae muscle for all of those functions, right? So needless to say, I'm reusing this illustration that actually shows all 3 cranial nerve nuclei or nerves that move the eye. We're only focusing on oculomotor in this case. So once again, in a cross-section looks like this. So you're looking at mid-level or rostral midbrain, where you can see a superior colliculus. That's your landmark when you look in that tectum. And then you observe the cerebral aqueduct and the periaqueductal gray, and just ventral to that, the oculomotor nuclear complex, next to our good friend, the medial longitudinal fasciculus, right? You remember what the medial longitudinal fasciculus does. It coordinates these eye movements and so much more, vestibular functions and everything else. Some of it might even go to spinal cord, okay? So the important thing is that you'll find the somatic and the visceral motor components in the oculomotor nuclear complex, right? So oculomotor deficit may be a result of an oculomotor nucleus damage. So that could be up here. So it could be up here, so there might be a lesion up here. And the nerve comes out like this. So again, medial most, what is it? Somatic motor. Well, heck, the parasympathetic motor, just the way it develops, it grows into the same nerve. So there is no separation, okay? But I think of it as primarily representative of somatic motor nerve very close to the midline. Sure enough, it's coming out of the midbrain at the interpeduncular fossa. So there might be a vascular insult or some other type of insult at the nerve root level. The same clinical sign is called ophthalmoplegia. The eye is called down and out, oculomotor palsy or complete. That's ophthalmoplegia. Okay, not internuclear ophthalmoplegia. That's the unique case that we talked about for the medial longitudinal fasciculus damage. So the nerve root can be compressed or damaged, or the actual nucleus can be damaged. And sometimes it's vascular insult, and we'll talk about vascular territories later. Okay, maybe part of a brain herniation syndrome. I think you heard this before, right? So for example, the uncus of that parahippocampal gyrus is actually not that far, and the so-called uncal herniation, it could threaten these areas, also the base of that cerebropeduncle where the corticospinal tract is, and therefore you might get a contralateral hemiplegia. But let's put that in parentheses, okay? Because we still have blocks 2 and 3, and especially block 3, where we can look at this. So, but do remember oculomotor palsy and do understand where the nuclei are. And finally, looking at our trochlear nerve, again, I would expect that at caudal levels of our midbrain, coinciding with our inferior colliculus. And again, keep in mind that by the time you get to see that nerve, it has already crossed, because internally crossed, and not only that, of course, it comes down from the dorsal aspect that curves around and gets to the eye, like that. So it has, just like the abducens, an extraordinarily long subarachnoid course, and these nerves are vulnerable to insults. And of course, that will give you a peripheral type of lesion that can be from inside the cranium, or can be in the orbit. So we'll get into that, the various types of lesions. So it decussates before it emerges, innervates only one muscle, superior oblique, susceptible to damage. Awesome. At the very end, notable cranial nerve reflexes, by way of reviewing. Gag reflex, the sensory arm is in cranial nerve 9, glossopharyngeal. Motor arm is in 10, vagus. Blink or corneal reflex, an important one. The sensory one, that's where you touch the side of the cornea. You're not stabbing anybody in the eye, but the side of the cornea with a cotton wisp, and you look for the closing of the eye. The ophthalmic division of trigeminal is the sensory, motor is 7. Jaw jerk, the only stretch reflex that we can test. An important reflex, normally practically non-existent. Okay, so that's what I want. That's what I want to see. Barely or not at all when you tap the masseter. Okay, when it's exaggerated, that's where I'm expecting an upper motor neuron lesion, something intracranial, potentially hemispheric. And the pupillary light reflex, the sensory arm, is in optic. Right? It needs eye, it needs the retina, and even beyond that, it needs pretectal area and superior colliculus, all that good stuff. Motor arm is via the parasympathetic division of oculomotor. And that's all we had for cranial nerve nuclei. So I will see you next time.